welcome once again to an EMDR chat with Curt and Michelle. I'm Dr. Curtis Rounzen.
And I'm Dr. Michelle Gottlieb. And Curt, that was trickier for you to say than you thought, was it?
It was, yes.
All right. Good morning, everybody. It is morning for us, whenever time you listen to it, but it is morning right now, and that's the reason perhaps we're stumbling over our words a little bit. So last time we did a podcast, we were talking about eating disorders with Dr. Jonna Fries, and we discovered we had so much to talk about that we needed a part 2. So
and there was a great deal of interest.
Yeah. Oh, it was great. And so I know all of you are probably going, when is the part 2 happening? Now. It's happening now. So Dr. Jonna Fries is back again for us to continue to talk about eating disorders and EMDR therapy. So good morning to you, Jonna.
Good morning.
Good morning.
Good morning. So happy
Good to
be
have you
here
back.
with you too. Thank you.
So last time we talked about how ways EMDR therapy can help treat eating disorders. You were talking about using the standard protocol and what's helpful about specialized protocols. You talked about phase 1, history taking, phase 2, preparation. Today, let's talk maybe more about target selection and what other phase-specific stuff we might want to do. Is there anything else? Do you want to start with that, or do you kind of have another place?
Sure.
Okay.
Well, one thing I wanted to cover just super briefly before I go into target selection is just the different types of feeding and eating disorders.
That's a really good
yes.
idea, because I'm starting to hear more initials now than I ever have, like ARFID.
ARFID. Mm-hmm.
ARFID. Yeah. I'm like, wait, these are more initials. Yeah. So please, thank you.
Yes. Okay. So in the DSM, there are 6 specific feeding and eating disorders. And of course, the most well-known is probably anorexia nervosa, which is actually probably the rarest. And I also find this super fascinating because everybody knows about anorexia nervosa. Not many people know that DID is actually more prevalent than anorexia nervosa. I just thought that kind of
Isn't
blows my
that
mind.
interesting?
That's
fascinating.
It is.
Yeah.
But anyway, so there's anorexia nervosa, there's bulimia nervosa, there's binge eating disorders. Those are the 3 main eating disorders. There's also pica, which is eating non-nutritive, non-food substances. I've actually never had a case of that. There's also rumination disorder, where people will chew up their food and spit it out. And then there's also, as you were saying, Michelle, there's ARFID, which is avoidant restrictive food intake disorder. And so this used to be called picky eaters. But the problem is that there can be severe nutritional deficiencies in people with ARFID. So those are the ones that are actually in the DSM. You may hear, and there are other there are other ways of eating disorders being manifested into severe pathology that are not quite captured by the criteria for those 6. And so those can be diagnosed as OSFED or other specified feeding or eating disorders and still get that DSM diagnosis. So it could be an aspect of anorexia that doesn't quite meet the criteria, but still you can have that DSM diagnosis with OSFED. But other things that you may hear about or other listeners may hear about, have you ever heard of bigorexia?
No, what's that one?
So bigorexia is, think about severe people who do a lot of weightlifting, but there's that dysmorphia where they think they're small. Okay, so that's bigorexia. Have you ever heard of drunkorexia?
No.
So drunkorexia is really using alcohol and under eating so that you can save your calories for alcohol.
Oh, interesting.
Okay. You may have heard of orthorexia. Have you heard of orthorexia?
No.
Okay. So orthorexia is this obsession with eating cleanly. I mean, come on, you're both from California. You know this, right? So orthorexia, actually, the term was defined, if memory serves, by this guy who eventually found himself only feeling like it was okay to eat food that he had pulled out of the ground within the last few hours, and eventually realized, like, this is absolutely dysfunctional and not sustainable. So, living in California, we're exposed to a lot of, what people might term as biohacking, things like that. But, this perfectionism somehow with eating super clean. So that's orthorexia. Diabulimia. Have you heard of this manipulation of insulin?
Oh my goodness.
Which can be lethal.
Yeah.
That people may use to lose weight. And then there's night eating. And then there's also pregorexia. Have you heard of pregorexia? Oh, yeah. Okay.
I have heard of that.
There,
yes.
Yay, ding, 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 ding. Okay, well, So pregorexia is this fear of gaining weight when one is pregnant.
Mm-hmm.
Okay, so I just thought it was important to kind of cover all of those. And I think I touched on this in our part 1, but I want to highlight this transdiagnostic treatment of eating disorders. And I want to highlight how that is very similar to the transdiagnostic treatment of the underlying trauma. So when we think about EMDR and treating trauma, we're not only thinking about big T trauma, we're thinking about those dysfunctionally held memory networks that are held in this traumatic way, right? And that is what we're treating, no matter what the diagnosis is, that is what we're treating. And similarly with eating disorders, there's this through line of what we're actually treating. And so what we're actually treating mostly throughout eating disorders is this negative self-image based on body size and shape. So that really lends itself to this transdiagnostic treatment, which is very similar to how we approach our cases with EMDR. Okay.
Fascinating.
I think so too.
Yeah.
Mm-hmm.
I swear, I'll never be bored, ever, ever, ever. Our world is so fascinating.
Right? Absolutely. So the treatment plan, and again, we see this in so many things, that it's not going to be on the symptoms of whatever eating disorder they have. The treatment plan is going to be on that I'm not good enough, I'm not enough, however that gets framed for them.
Yes, and
yeah.
So I'm about to go into target selection, which it can be everything. Okay,
Sure.
So that's what I want people to wrap their minds around, and probably everything I'm going to say is something people have already thought of, but just hearing it is another exposure to conceptualize how broad an eating disorder affects our lives. So in thinking about just conceptualizing our cases with eating disorders, we have to conceptualize in a way that's deeper than for a big T trauma. For a big T trauma, which are those unicorn cases, it's very straightforward. With any kind of complex trauma, like you would find with an eating disorder, we have to take a more considerate and thoughtful path toward conceptualization. And so we talked a little bit about protocols last time, and this is where I want to highlight that where protocols can be helpful. So a lot of the information that I put together for this is from, compilation of different articles and protocols, because not that you're going to follow step by step. Some people may be able to do that. I can't do that. But most protocols will give you a lot of information about the disorder. So I do think that that's where they can be very helpful. So when we conceptualize for an eating disorder, there are different methods or pathways for people listening, I'm pointing with my fingers. There are different paths for conceptualizing how we're going to select a target. Okay, so some of those might be how we're used to with EMDR, where we're going to select an intrusive or disturbing memory, okay? Or we can conceptualize in a timeline manner. And that's also, so with EMDR therapy standard protocol, it's the earliest or the worst. So we can do that too with eating disorders. But we can also really start to think about symptoms, like you were saying, Michelle, maybe we don't necessarily target exactly the symptom, although we can, but maybe we start talking about a symptom and we try to understand what happened that led us to initially having that symptom. What was the precursor to developing that symptom?
Right.
And then also we can, it's interesting. When I first heard the idea of targeting a cluster, that sounded very amorphous to me, and I didn't really get it. And I just want to clarify that when we target a cluster, we're still anchoring the memory that we're targeting in a specific time and place.
Right.
So we're
Correct.
getting the best representation of that cluster. Okay. So we can do that with, let's just say with eating disorders, if we're targeting a cluster, that could be around a dysfunctional belief. Okay. So with that dysfunctional belief, we're still targeting that we're anchoring it in a specific memory that has an image, that has that negative thought and everything. Okay.
Right.
Mm-hmm. Okay, so I'm going to talk about lots of different types of targets. So there can be memories. This isn't in any particular order, but this is the one that is probably most common. So memories related to body shame and food shame. So that can be a specific event. Very commonly, it's around family, and it's around maybe family dinners were very stressful. There's often, I don't know if either of you have come across this, but I find there's often a double bind message from a parent who basically makes certain foods available and then shames the child for eating those foods. And that's often, it's like having a binge buddy. So I want you to eat this to assuage my own shame and guilt and fears around food. But then I also want to do to you what I do to myself, which is shame you for eating these foods and being in what I perceive as an imperfect body.
Right.
Yes.
So that's, sorry, Curt.
Well, it's like, and there, I assume that there's also some of the emotional components where food is used as a replacement for affection.
Oh, absolutely. Absolutely. Yeah. Affection, attention, purpose, meaning, joy, other ways of getting joy.
Right. And I was also thinking of all the ways that the whole thing can be around control as well. You know?
Oh, yes. Yes. That's huge. And interestingly, one would think that control might only lead to anorexia, but that's not true.
Right.
I mean, control can be part of any of these eating disorders, and it's an illusion or delusion of control, right? And the illusion is that if I can control, then I will be okay. If I can control, then I will be loved. If I can control, then I don't have to feel shame. So it's not true, but it can, one can literally take that to the grave.
Right.
Well, it reminds me, when we talk about addictions, how an addiction is a solution, and this is the same for an eating disorder. It's a solution to something, and it works for that particular patient. Has detrimental side effects, but
not a healthy solution.
Right. It solves that problem for them at that moment.
Yes, and very similarly to an addiction, there are very powerful neurophysiological implications of, like, if you think about an addiction where there are neurophysiological, it's like you get on a roller coaster and you don't get off till the end of the ride when you start thinking about engaging in that addictive process. We like to think that it's the injection of the drug or the swallowing of the drug, which is where the neurophysiological components start taking place. No, it's when you start engaging in the thought process, very similar to even process addictions. But with eating disorders, it's much more physical than, say, gambling or, other shopping, just very more clearly process addictions. So I was going to also say about these memories, there's often a history of bullying or shaming around the body, being, bless you, being objectified, being sexualized, something about the body that is just untenable at a certain age or time when an adult often is viewing the body as something other than, the corpus that we're moving through life in, and it often has to do with that person, their fears, their shame, their narcissism, and they're projecting that onto the child who then, introjects that and has to carry that. So let's see. Oh, there's often, we can also think about targeting negative body image. And so this often has to do with specific body parts, specific shape. This is very cultural. In, different cultures throughout time, things shift. And, what once is a desired body size and shape is now no longer desired. So when we can target, the hatred of a certain part of someone's body. We can target distressing or intrusive images. So these can be flashbacks to a certain moment in time, or maybe a photo that they saw of themselves. Of course, this can be related to social media. It can be someone that they've compared themselves to. It can be a moment from a body shaming incident where, their peers somehow shame them in front of someone, or a romantic partner shame them about a body size or shape. It can, apart even from the image of the body size or shape, it could just be a body sensation. Mm-hmm. So I can feel my stomach. I can feel my thighs. I can, feel my fullness. I can feel my emptiness. I, feel too big, too small. Okay. With that bigorexia, I'm too small. So we can also target the idea of being anorexic, bulimic, or binging, in how this can show up in non-food related aspects of life. So is somebody also anorexic in the way they allow themselves to spend money or decorate their home? Mm-hmm. Are they bulimic with jobs or friendships? Do they, binge on things, and there's that sort of out of control aspect in their life. We can also think about those eating disorder related fears. So if I don't, these are really blocking beliefs. So if I don't starve or hate my body, I'm going to get huge, and then I will be unloved and isolated. It's that, gazelle separated from the herd feeling. And so that's very terrifying. When I first started EMDR therapy, I guess this was, this was when I was doing my certification. I had a great consultant who taught me to target the fear of doing EMDR with a client. It was so meta and mind blowing. Oh, you can do that, right? So these eating disorder related fears often have to be targeted first, just like that. The fear of doing EMDR therapy, similar to DBT, we have to target what gets in the way of them being able to participate in therapy first before we can move them along and perhaps target some of these other things. Good. Were you going to say something, Curt?
No, I just said it's like targeting the defense.
Yes.
That we talk about in EMDR therapy.
Yes.
And one final thing I just want to ask real quickly, and that is, AJ Popke came up with the idea of the deter model of targeting the urges. And I'm curious if the urges to engage in some of this behavior can also be a target.
Absolutely. Yeah. And that's when, Michelle, when you were saying initially, we can target these other things instead of the more eating. So that's what I would target. I would target the more eating related behaviors and thoughts with some sort of feeling state protocol or detour. That's where it gets more directed to the eating disorder and not the underlying factors.
And we are, again, about out of time, and there's still so much more. Jonna, can you just direct people to some resources to continue their education?
Absolutely. So I would say Marilyn Luber's, I think it's a 2019 protocol. There are a couple of chapters in that book that are super helpful. And then also the organization IADEP, International Association of Eating Disorder Professionals. I've been a member since, I believe, 2005 or so, and active in that organization. They have a certification program, the only one that I know of in the field of eating disorders. I'm not certified. I'm not a certified eating disorder professional, but they do have a really good program for that. And there are also you have advanced training on eating disorders and EMDR specifically, right? Andrew?
Not yet.
No? I thought you did.
Not yet, although, Jonna, that might be something that we'd be talking to you about.
That's a great idea.
Well, that will be something that people can go to in the future.
Right? We do have the detour, the urge reduction.
I see.
That Curt was just referring to. We do have that.
Okay.
But Jonna, thank you so much good information. Really do appreciate it. And again, everybody, please remember that we will put a 10% discount coupon for just thanking you for being part of EMDR Chat with Curt and Michelle. We do appreciate it.
Until next time.
Take care, all.